Hi, I'm Sacha. I'm a cardiologist by training, and I am the Chief Medical Innovation Officer at Women's College Hospital. So thank you all for coming to our beautiful new space, relatively new, I suppose. And also the the founder of Weave, which is also the co-host of this event tonight. And for those of you who don't know what Weave is, it's basically an incubator and an evaluator for applied research. And we didn't start out as a digital health research institute. We started out just trying to figure out what were the big problems and challenges in healthcare and how do we figure out how to solve them. And looking at emerging trends from things like big data, quality improvement, health policy. And honestly, digital health was kind of the area that became, in our minds, probably one of the most important transformative trends that we were seeing in healthcare. And as a consequence of that, we thought this was going to be really important to get into. And ultimately, our goal was to figure out how do we do it, not just do it, but do it well. And, there's a lot of, and so I can just say, editorializing, there's a lot of people who say or who write pretty negative things about the Canadian healthcare system, and you probably have heard a million or read a million different think pieces and tweets about how broken it is or how unresponsive it is, how we still use the fax machine, and some of that is true. And I'm not going to say that we don't have a ways to go, but I'm super optimistic. In the past 6 years working with innovators in companies, researchers, government, and patients and caregivers. To see how far we've come in the past 5 years. And it's embodied by the fact that it's Thursday night at like 7:30. You guys have probably a bunch of other places to be, and yet the room is full here of like people who really want to make a difference in the healthcare system, whether you're an innovator, an implementer, or you're a patient or you're a provider, and you really want to make a difference. And our digital health transformation is going to come from people like you. And our job at Weave is to help shepherd that along and to help that transformation happen and to make sure that we get it right and that it's good for patients, it's good for providers, and it's good for the system so that the system will be able to support the innovations that you guys are providing, not just for you, but for your kids and your grandkids into the future. So I'm super excited, to be here. I'm super happy that you guys have taken your Thursday night to hear us talk. But more importantly, I'm really excited to have a dialogue with all of you about like where we want to go and ultimately how we want to get there. So thank you very much.
So we're doing introductions now? Is that what we're doing? Because did you get into the substance of what you wanted to get into, or are we just? Are we skimming the surface?
I think we're skimming.
Okay.
We'll get in there.
So no. But seriously, I'm asking a format question.
It's an introduction.
Okay. So,
but thank you, Sacha. It's very informative.
I love Sacha and Weave, and we fund them to do partly. So, as was noted in the introduction, my name is Greg Hein. I'm a reluctant bureaucrat. I love the part of being a bureaucrat and that we can influence big levers like legislation, regulation, and funding, and we can create an environment that fosters innovation. I'm a reluctant bureaucrat in that I'm not supposed to have any opinions whatsoever, but I like to have opinions, and you'll hear a few tonight. So please don't consume me through your social media in a way that makes a caricature of what I'm going to say or pretends it's an announcement of the government. I say this seriously because it's happened before, but it's an important point that I will work as hard as I can for whatever government's elected and drive the digital health agenda through that government. We have a lot of money to spend on digital health. I'll disappoint you up front. It's not going to be a little pot that we give you, K's and small M's. We're going to create an environment that fosters innovation in a structural way, in a policy-oriented way, and that's what you'll hear tonight from me.
Hi, everyone. I'm Alexandra Greenhill, and I'm a physician by training. I was also a patient for the first 12 years of my life, which I think informs why I keep fighting the system to try and improve things, because my mother was told several times that I was going to die or the surgery went poorly, and then people intervened, and here I am, knowing more about the healthcare system on a daily basis. And I'm glad because I now have a Twitter account since 2012. Before that, I didn't have an opinion that I could express, but it's fun to be on the other side. I've done everything from computerize my hospitals to teach people how to do it, to do IHI, telemed, EMR implementations across thousands of doctors' practices. And I'm now running Careteam, which is a new type of software that sits in the middle of all of the awesome technologies that are being created and allows them to come together in a way that's personalized around each patient. The average patient has 7 chronic conditions, and they need at least 5 or 6 or 7 apps and devices and tools to help them. And so I'm excited about making other people's technology come together in a way that makes sense, as opposed to overwhelms each patient. And so Careteam is a member of the supercluster in British Columbia. We have one project that is part of the first waves, and happy to talk about that too.
Hey everyone, I'm Will Falk, and I am a former PwC partner. I'm a recovering management consultant. I spent 25 years of my life in New York and Toronto doing that, and since then I've had the chance to work with some great teams, including both Greg and Sacha's team. So I'm a fellow at Weave, and Greg and I have conspired on a couple of things, including I guess we first worked together the 2011-12 fee negotiations. I'm sure I'm going to work for Alex at some point, and I'm looking forward to that. I have a bunch of conflicts because I work for or invest in several software companies, including Think Research. I see a bunch of them here, and Verto and AlayaCare. And I'm also on faculty at the U of T. And just really pleased to echo what Sacha said about how great it is to see all of you here today, and looking forward to the discussion.
Great, so we're going to start with a few questions, and then we'll open up to the audience. So my first question, Sacha, is about patients being the unifying thread in healthcare. They are the only people that observe the entire process. How do we ensure that patients and caregivers are included now and moving forwards as we redesign the Canadian healthcare ecosystem?
It's a great question. So I think one of the first things we need to do is include them and ask them. And, for a long time, there's sort of this whole adage in healthcare, which, around the patient experience and the patient, engagement, which is sort of with, like, what is it? Something like with me. It always has to be with me. Anyways, I'm not going to get into it. I can't remember the exact expression, but nothing to me without me. There it is. Thanks, Will. And the idea is that, for a long time, healthcare, when we think about what we fund in terms of interventions or what we deem as success, it's predominantly been framed from a provider lens. Meaning, we care as a scientist about hospital readmissions and about death. And those are important metrics. But for a long time, the patient experience has sort of never been characterized or ever really been measured in a substantive way. And we've never really asked. So the reality is that, in Canada, we can go to hospitals and you can get care where patients feel marginalized, where they don't feel listened to, and where, quite frankly, from a patient perspective, the care episode was an absolute failure. And yet, at the same time, they didn't die, and they actually got sort of evidence-based care delivery, and we would consider that to be a success. And I think one of the things that has held back digital health and the digital health solutions that many of you are looking at that that haven't really happened as of yet, and I think the ministry, to their credit, is really looking at this, is they don't necessarily change outcomes in terms of death, like a pill or a drug or, say, for example, a type of surgery, but they do save patients time. they do take into account their experience and prevent them from going into hospital, sitting for 3 hours to have someone like me come in and say your test results are completely normal, and then you can go home. And you're like, why did I take a whole day off work and then pay for parking and then go in to literally have somebody just tell me that I'm normal? Why couldn't I have done this over the phone or by email or like any other reasonable industry does? And I think the idea is, as we start asking patients what matters to them, we start measuring what matters to them, measuring their experience, not just of patients, but of caregivers. And we start flowing money and designing interventions that actually change the patient experience and take that into account in our equations. We're going to see fundamental shifts in the way that we deliver care. Because right now, there's no incentive for physicians and hospitals to change the way that they deliver care. I think, to this government's credit, the Ontario Health Team model, where they're thinking about integrated care and the patient experience, is going to unlock a lot of that, and I think you're going to see a lot of change.
Totally support that vision. And I think the one thing I'd like to add to it is, we figured out in healthcare that the silo approach doesn't work, and we need to start working as a collaborative team across professions, across organizations. And I think a time has come to start acknowledging that most patients facing a very complex and scary illness can't face it alone. And so if you're diagnosed with cancer or diabetes, with multiple comorbidities, having a team around you makes a huge difference. And so, none of my patients' caregivers describe themselves as caregivers. They don't talk about like the adult daughter or son is the adult daughter or son. They don't think about them. We need to find a new way of saying family, maybe chosen family. We need to start articulating a different language around this space, because my patients in real life that get better are the ones who actually show up with someone that has a binder underneath their arm, keeps track of all the appointments and ensures things happen. And then that person is not the only person, because otherwise they burn out. And then that person ends up being the burden of the system and costing a lot more. But having that social circle around them makes a huge difference, almost equal to some of the treatments that we offer.
So building on that a little bit, I'm going to pass it back to you, Alex. We are a diverse population, and with this comes unique use cases and variability in users. So how can we create health tech that adapts to this diversity, yet enables us to collaborate?
That's a fantastic question, because I spend a lot of my time educating people to stop selecting patients, because our guess about which patients are going to adopt technology is just about as good as our guess on how long they're going to live. And there's lots of evidence around the fact that we're wrong on both. And so we had a very interesting experience where we gave our software to people who are on average age 75 and older, caregivers of patients with dementia. They used our software for 2 weeks. There were 8 of them. They came together, focus group, talked about it in the morning about how this was a godsend and a lifesaver, and they produced calendars out of their pocket that were crumpled and said, if I lose this calendar, nobody knows what happens to my wife. In the afternoon, we had a group of physicians, nurses, and social workers who ran in, and they arrived late. They had to leave early. They had to take phone calls in the middle of the focus group. None of them had installed and used the software, because they came in and they said that none of their patients would ever use it. And so, it's interesting to see that sort of a disbelief around the fact that people will embrace technology. Turns out your grandparents, same as teenagers, they get now hand-me-downs. They get the oldest generation of phones and laptops and iPads that somebody gives to them, and they have time to learn how to use them, and they're not that bad. Or they have someone in their life who'll step in and use it on their behalf. And so we shouldn't treat and assume that just because they don't speak English as a second language, just because they are older or immigrants, they can't access technology. And we should invite everybody into that age, but also build tools that allow us to acknowledge that the ones who cannot use technology need a paper-based model or some other version to still access services.
So on that note, let's talk about inequity, Will. How is technology going to address the disparities in Canada's populations? Will it change inequity, and will it help those with lower socioeconomic status?
So I want to touch on the social determinants piece that Alex was just talking about, because I think it's really important, right? I mean, what we're saying is that the social milieu that you exist in is important from a technological point of view when you think about the circle of care that you're creating around someone and what that looks like. And that can be, for some people, not all people, digitally enabled. What's really interesting to get into here in the equity piece is that you'll often hear people talk about health equity, and what they'll say is some version of, and pardon my straightforward language here, but some version of, poor people don't have computers, therefore solutions that use computers won't help anyone except the rich. And that's a 10-year-old idea that isn't true anymore. Now, I want to say, as I say that there are indeed marginalized populations, and I'm going to come back to them, for whom that is true, but it doesn't divide the way that it did 10 years ago on income. If you look at the RWJ numbers on income spread and iPhone usage, you will see that there is no meaningful difference anymore amongst phone usage by income groups, right? Where there are groups like indigenous populations, mental health populations, and others that aren't using technology, there are different reasons, cultural and socioeconomic, that we have to address. But I want to start out by saying that I think we've got the health equity thing on virtual and digital backwards, and that we're playing defense when we should be playing offense. The truth is if you're a single mom in Toronto, you want access to virtual care because you want to be able to not have to take 4 hours off work and arrange childcare so that you can go and get a prescription removed. And when we play defense on health equity issues, instead of talking about where we have a health equity positive pickup, we end up defensing ourselves off into this weird-ass world of Akira, Maple, and Babylon, where only rich people are using the virtual care. And that's not what we're talking about, right? What we're talking about is creating relevant platforms that people at all socioeconomic levels can use within the Canadian healthcare system, not private virtual care walk-in clinics. And I want to stop playing defense on this.
And Greg, the Minister of Health recently unveiled the provincial Digital First for Health strategy, which includes more virtual care options, greater data access for patients, and better access to health records for providers across different institutions. What opportunities do you see local innovators playing to improve healthcare services for patients and providers, and how do you see these groups collaborating to support the objectives of the strategy?
So I said in my introductory remarks that we want to create a competitive environment. A lot of the digital health world is not competitive. We have big multinationals at play. We have large Canadian companies that love a locked-in market. Our interest is in making it highly competitive. So here are a couple of ways that we're going to do that. One is, what's the business model? A lot of it has to do with money. We have been spending a lot of time with the OMA, the Ontario Medical Association, in a really collaborative partnership to clarify, starting with virtual care, what are the financial incentives to provide virtual care. And we've reached one major agreement on video conferencing, and that was recently announced. And that says that you can get the same amount of money virtually as face-to-face. And that may not sound like a huge deal, but it was a pretty major milestone. The next step is, not many people, including myself, want to video conference with their doctor when I'm sick in the morning. I want to use efficient, secure messaging. So the next step is to figure out how to bill for that, and we're going to do it. Another step is Ontario is well placed with having the Ontario Telemedicine Network. And if my friends and colleagues from OTN were here, I'd be applauding them. I think they recognize that their model needed to change, and we have to move away from OTN and accept any technology that people want to use if it meets certain privacy and security requirements, and we're moving in that direction, and that's going to be a major milestone. So that's one area. The other is, doesn't it make you mad that people can still block the flow of information? It is insane how that happens. And is it the fault of PHIPAA, the privacy legislation? Not really when you read the legislation, but it is the way it's been interpreted over the last 10 years. It has been interpreted, and no offense to you or your friends or your family that are legal counsel, if you are legal counsel for a health service provider, your job is to limit that organization's liability and to inhibit the flow of information. And this government is willing to modernize PHIPAA in a way that still has amazing privacy protection, but improves access to your own PHI. If you read PHIPAA, the provider, the HIC, is at the center of it. This government is willing to explore how to put the patient, put the consumer at the center of it. And that may involve a right to access your information digitally. I say might because I'm a bureaucrat and I'm not speaking on behalf of the government. But the time has come to do that. Another thing I'll mention is baby Spark. Spark is this little, well, Spark is intrinsically a small thing, but it's this project with UHN, Mars, eHealth Ontario, the ministry, to figure out how third parties, I don't care who you are, third party, call yourself an innovator, call yourself a researcher, a third party can get access to all of the hundreds of millions of points of data in our repositories through consent of patients, but who cares? Patients will consent to your amazing apps, as opposed to the apps up to this point, which put the burden on the patient to input their own data or are tethered to a single institution. We want to open up the treasure trove of data that we have to you, and PHIPAA modernization includes this new, potentially, this new ability for consumer app providers to have that direct relationship with patients, God forbid. And that we think will be an amazing boon to innovators. The last thing I'll talk about is Ontario's never had a digital health information exchange. Fire-based APIs for our stuff, for frontline systems, that alone will open up the market and allow Ontario innovators to create value-added apps, including, yes, so Cerner, Epic, a lot of companies have, they publish their APIs. We're talking about a more structural approach that also includes a minimum data set for what information is shared across the continuum of care. And there's a whole bunch of other stuff that we're going to do, like patient digital identity. All these structural things, going back to my comment about a little honeypot of money that gives you like 50K or 100K really isn't what it's about. That was tried in the past. It's these big structural policies and getting at the funding that will really help you, I think. And you help us, because we're not going to do what you're going to do. We want you to be the smart innovators. Thank you.
Do any of you want to comment on that?
I mean, we underestimate the degree to which that digital infrastructure matters, but we cannot continue to build the wheel in every organization, in every hospital, and reinvent it. We should just decide that their basic shape is a wheel. Maybe sometimes it's a bicycle, it's a tricycle. We need 18-wheelers. Let's something where we start exchanging. And I've practiced in Quebec, I've practiced in Ontario, I've practiced in BC, and everyone fundamentally believes healthcare is different, but it's not. It's a human who has a health problem. That human needs to be assessed, treated, supported in treatment, supported in whatever phase, whether we can cure this or live with this. And someone at the end of the day pays. It all comes out of the same sort of a purse. And sort of like, let's stop arguing about how we're different and let's start looking at what we're doing that's similar and start importing interesting projects. And I think it's time to actually start accelerating some of that, because as an innovator company, and I know that some of you have the same experience, we get callbacks faster from the NHS, from Sweden, from the US, all over the place, instead of all of our hospitals here in Canada. And it's a travesty because I, as a Canadian, would love to help where I live, where my parents live, where my friends and family lives. And so we need to accelerate some of that procurement process in order to make all of this much more effective.
Thank you. We're going to open it up to the audience. So if you have a question, you can put up your hand, and there will be a few mics that will come around. If you're in the front, I'll pass you mine.
Hi, thank you for all the information and initiatives you represent. I want to kind of echo what Alex is saying, but ask a question around it. So as a health institution that wants to do innovation, there's a few obstacles today. Procurement, as you mentioned, is kind of broken, especially when you want to buy from startups. Incentives for innovations, don't know where they are, except people wanting to do it, but what's the institutional incentive or economy incentive? And like on the other side, when you look at other jurisdictions, even from the government side, allocating budgets for innovation only, because I think that this room knows very well, the future is not going to come from the large companies. It's going to come from the innovators in this room and like them that see 10 years into the future and develop things that maybe today are not there yet, but we need to work with them to get there. How do we allow institutions like we have to buy that?
So I'll cherry pick one part of that to start off with, and that is a personal opinion, not professional, that it does bother me the risk aversion in BPS procurement. There are in-house people in health service provider organizations and a few well-placed legal counsel in the province of Ontario that will make it virtually impossible for you to get your products acquired by hospitals, at least, to focus on them. So I think this government might have an appetite to change the BPS procurement directive as long as it's compliant with international trade law. I'm not trying to be critical, but a lot of innovators sometimes have sloppy, lazy views about just support Ontario products. It's never going to happen. That's not really the point. You just need to be able to have open, competitive environments that, and I think in some ways you're disadvantaged by the way that procurement directives are interpreted. I guess the other point is that we want Ontario health teams to be purchasers and innovative purchasers. And we did a digital playbook to kind of encourage them in that direction as long as they're evaluated by a third party, Weave or otherwise, as long as they have contracts, provisions in their contracts to be scalable. But those are two things. I'll let others speak to other aspects.
There's a set of regulatory and pricing rules that have been buried inside of the OHIP fee schedules, inside of regulations that block innovation for some really important reasons. Some of them are good, okay? And I posted online, and you can have a look at some work that Sacha and I did on this at CD Howe around pricing and regulatory reform. You know, some people don't get the fact that queues, having lineups for services actually serves an appropriateness function, forces people to organize care, to treat the highest needs people first. It does a whole bunch of things that are hard to let go of. And one of the things that we do in the virtual care world is we take the sand out of the mill so that you can run a process much, much quicker. And you see this in areas like teledermatology already. And for a whole bunch of understandable reasons, people are cautious about taking that governor off the system, taking the physical governor. So to say it in a slightly different way, by insisting that physical contact happen when you deliver a care process, what you do is you limit the capacity. When you take that governor off, you open the capacity up wide, which is great for consumers. But if you're paying the bills and you're paying at the same price you were before, in a fee-for-service system, you can have your budget explode, right? And so what we've done is we've used regulatory and pricing barriers to keep control of the system. Greg's talking big change, which I think is absolutely right, and I commend the DHS for the good work that they're doing on this. I think it's really important. We need a wholesale review of all the prices and all the regulations. We need to understand when physical contact should be clinically necessary and when it isn't. And then we can have innovation behind that. Because what we're doing right now is inherently Luddite regulatory and pricing that insists on physical contact as a way of delivering care, and that just blocks the whole thing. Now, everything he said about BPS is true as well. I'm not taking away from that. I'm just saying there's a broader context here that we have to go to.
But, well, love, like you incited me to disagree with you before this started, so I found something. Excellent. And so, I mean, this is, and it's usually hard. It's really interesting that sort of a myth that if you open telehealth, fees will explode. It's the fear of every government. Where telehealth was not introduced, but the evidence from every place where it was introduced, including Kaiser, that has had it for forever, is that it actually, people don't call their doctor unless they are worried. And we have mechanisms as physicians to limit how many times patients see us, because if my borderline personality patient or anxiety-driven patient shows up at the office every day, I can still build a system for it, but we don't, because we find a way of managing that anxiety and structuring the relationship in a different way. And so there's this theoretical fear that once you create telehealth, people call you all the time. I find the opposite is true, and I've practiced telehealth now for 10 years. My patients with anxiety, knowing that they call me at any time that they need to, don't. They have like a backup option in their pocket, and they're more relaxed about it. A patient who uses telehealth to avoid an emergency visit actually saves the system money. There's so many evidence of that, but no one's looking at evidence from other jurisdictions. Everyone says, well, we need to practice, we need to do a 50-patient pilot with pregnant patients. And you're like, but wait a second, for genetic counseling, you're making people right now get into a car in the middle of winter, drive for 2 kilometers to the nearest hospital, get in a telehealth room and talk to the Vancouver genetic counselor where they could get in an accident. They only have half an hour slot to talk about should they or shouldn't they keep their baby. Like, none of that makes any sense. And, there's these theoretical concerns, but the reality is not the same.
Okay, so we don't disagree, of course. No, because what I was trying to say is that we're at a stable equilibria that is dysfunctional. But when you're at a stable equilibrium point that's dysfunctional, it's very hard to manage the economics to get out of the stable equilibrium and move to the totally obvious other equilibrium point that Alex is quite correctly talking about, right? And so we're at a Nash equilibrium point, and we can't get out of it. And how do we break it?
I'm going to sense that the audience doesn't want to talk about virtual care the whole evening, right? So, and I'm also going to pat myself on the back to say, we've got virtual care under control. Like, honestly, the truth lies somewhere in between them, because there are people that pay for this, Treasury Board, that is worried about the secure messaging side of it being icing on the cake of utilization. But you know what? We're going to do what Alex says. We're going to plunge ahead, and we're going to see the merits of it.
How did I end up being on like the back end of virtual? How did that happen, Greg? I mean, Jesus.
You're great, Will. I would encourage you to think about what you can do for Ontario health teams. This will be and will continue to be the biggest thing on the leading edge of innovation for the government. And you could say, oh, well, it's destined to fail. It's not as strong as an ACO in the States. There is a lot of determination to make these successful. to make funding models, support them. And for those that haven't heard much about them, it's essentially finding a way to have the holy grail of seamless integrated care, nice transitions in care. You know, it solves the Thanksgiving or Christmas or Hanukkah dinner problem of like you've got an uncle or an aunt that just doesn't have continuity of care. And we've got a lot of assets that help with pieces of it, but we don't have the solution to it. And you've really got to think about that.
So I'm going to kind of be the bad guy in the room. I think there are two, I think for a long time there were very big structural barriers that I actually think this government is going to address and is already starting to address. But it also leads to the big elephant in the room, right? Which is, ask yourself the question, are there a lot of hospitals right now in Ontario and other places that are saying, Jesus, if the BPS rules were different, we would be implementing all of these products all of the time? And the answer is no, like they're not, okay? And the reality is that we have spent the last 6 years dealing with hundreds of companies in the space. And it still surprises me how little engagement many of the companies have with actually understanding what the problems in the healthcare system are. Do these products actually solve the problem that the healthcare system needs? Not are they cool. I am certain they are cool. The question is, do they make a family doctor's day easier? Do they help a caregiver and a patient to actually get better care? Are they actually an administrative burden on people within the healthcare organization? Do they integrate with the dominant electronic medical record? It is shocking the number of places number of companies we have talked to who have said, we want to procure into your hospital. Does your thing talk to the electronic medical record? No, we'll deal with that later. I'm like, are you fucking kidding me? No doctor is going to use your product if they have to log in 4 times. They're just not going to do it. So the truth of the matter is that I think this government is actually going to move the ball very far ahead, and you've heard all the things from Greg about the policy stuff. And now actually the onus is going to be on the companies that are out there in the ecosystem to create good products. And this isn't an Ontario thing. I mean, we just had people from UCSF in, and we're talking about exactly the same thing, which is companies can't just be working on products in their basement, hoping that Google is going to buy them in 6 months. They actually have to talk to patients just like we do. They have to talk to providers. They actually have to test their stuff. They have to make sure that their stuff solves a problem and do the work that is required to create a viable, and this is what Greg says, a competitive product in the marketplace. And I guarantee you, if you have a good product, people will buy it. Unfortunately, for a long time, my unpopular opinion is that we have hidden behind BPS rules and all these other policy things when in fact, perhaps the products are suboptimal.
But it still goes back to that challenge of the real situation I was describing, where in the afternoon a whole bunch of clinicians came in, didn't even look at the product, assumed it was bad because they had PTSD from all the bad products they experienced before that.
Yeah, let's get some tough questions. Come on.
Hi there, Jonas Brandon. I manage a private equity group called Metric and advise Samsung globally on M&A and venture capital. And if you're looking for small pots of money, come to me, maybe not to Greg.
That's where it should be from.
I invest globally. I'm American, but I'm fiercely Torontonian at this point. I've been here for 13 years. And how to put this nicely? The healthcare is denominated in dollars. What you pay for is what gets provided. in the US in 2019, new CPT codes were introduced that, for example, provide for remote monitoring and patient engagement, and it pivots around physicians. I'm gonna get to I'll get to a question here in a second, which I think is a major step forward relative to Canada. There's nothing like that exists today, as I understand it, in Ontario specifically. But even that strikes me as pretty myopic, because if ultimately the physicians are billing for it, what we're doing is incenting the addition of more bodies to bill for more technology. At the end of the day, shouldn't we be considering reimbursing technology companies for delivering care?
I certainly think that paying, structuring contracts to be focused on outcomes is the way to go. And I think through innovative procurement, we're going to get there. I mean, I know there are some people in the room here that are interested in what I'll broadly call our navigation existing programs, whether it's Healthcare Connect or Healthcare Options or Telehealth. And there's a nomenclature issue in Ontario. Telehealth is a teletriage program, not telemedicine virtual care. I think we're going to be warming up for a major procurement in a completely different way for that would try to have the payment for that service based on outcomes. Fundamentally, though, I agree with you. And when it comes to remote patient monitoring, I think we're hoping that equivalency from face-to-face is enough to get, there are a lot of hospitals right now that are looking at virtualizing their entire post-acute, post-discharge assessments. And that would be on the backs of this equivalency policy. Do we have to create a remote patient monitoring, specific code? If we do, based on utilization, we will. Absolutely.
I have a question around virtual health. What I want to ask is, how do you set expectations about when is it all right to reach out to my physician virtually? And in turn, how are you protecting the physicians? Because I know that healthcare is now revolving around patients, but how are you going to protect the physicians who are providing virtual care?
So I think Sacha might want to weigh in on this too, because you did the evaluation of EAPC, but the enhanced access to primary care was a major pilot. It's more than really a pilot. At this point, it's really the stage one of a major rollout where primary care physicians can interact with their patients, and it's patient initiated, and those fears of doctors being overwhelmed by too many patient queries really weren't borne out. I mean, it's a kind of, someone mentioned the kind of caricature stereotype of, a crazy patient that never lets the physician sleep. You can set controls. This is technology that actually gives you more control as a physician than it would be otherwise the case. And so that's it. It's an amazing development. But Sacha.
Yeah, there are myths that virtual technology by necessity will drive physicians crazy. And the reality is we've done a number of different large-scale studies of large rollouts to find that in EAPC, for example, over 90% of all of the requests came from people who emailed or secure messaged their doctor once. So, the majority of people, it's like a one-off thing, because quite frankly, you don't want to be spending a lot of time emailing your doctor, to be honest. I'm sure you have better things to do. The majority of messages were actually, or concerns were answered in less than 3 messages. And there was only about 8% of people who are sort of so-called chronic users of the system. The vast majority of providers were very happy with the service, and they weren't terribly bothered by it. And honestly, the same thing happened with patient portals. So there was a concern when patient portals were launched that doctors would be inundated with, concerns that patients would see their data in their labs and would be emailing or calling their doctors immediately. And we've done evaluations of large rollouts in southwestern Ontario and other places and have not found that to be the case. In fact, so it's very, so to be honest, the data doesn't really show that out. I think generally my own experience as a cardiologist is it's like, actually patients have better things to do and are really respectful of your time. And I actually don't think they are over, there are obviously exceptions to the rule, but in the vast majority of cases, it's very reasonable.
What about miscommunication, or if there is a loss of information, if I'm not understanding what you're asking me to do, and if I do something, and if it affects me badly, am I going to sue you?
Right. So, I mean, again, litigation is something that everybody worries about. Extremely uncommon. The data shows it's extremely uncommon in Canada. But this is where actually good products really matter, right? And design thinking really matters. And thinking about, so in all the evaluations that we've done, there's actually been, in the EAPC project, a lot of work that happened on the design phase up front, which is, okay, so what does it mean when you get this alert? What does this lead to? So you can't just drop a technology into a care model and expect everyone to know what to do with it. You actually need to put in the work up front to understand you're changing the way that people are going to do business. We have a whole body of literature on this, and we've published a paper in Nature in this area around how do you redesign care, because technology in and of itself is ultimately going to change the way we interact. But you have to, and innovators, I think, have to play a role in thinking about, you can't just run fast and break shit, which is some famous innovators have said. You actually need to be thoughtful about how you actually go about doing it. And if you do, the actual evaluations of the data plays it out that it actually works pretty well.
Thank you. We're going to take another question from up here. So I'm just going to get you to pass along the mic.
Hi, guys. So here's a quick question. When you think about disruption in any other marketplace, like let's just use Amazon as an example. They come in, and when they digitally revolutionize, they come with not only a new front-facing solution, but the infrastructure behind it has all been changed at the same time, which creates the ability for a new model of care to present. So one of the things, I love what you're doing. I'm kind of jealous of the time that you have in the government right now to actually blow up some stuff, so.
You were there too early, Michael.
Yeah, when I couldn't blow up stuff, so. But the thing is that one of my worries is that by the nature of the healthcare system, there's a certain protective layer that doesn't let you change that root infrastructure. So where do you draw the line? Where is the line where the ministry and hospitals say, we're going to fix the infrastructure here so that the innovators can play with the right data and the information and the identities that we need to work with?
It's a great question, and it's an intrinsically conservative, small c, not political, conservative system that's held in place by very powerful interests, mostly related to money. Just declaring that we're going to do an information exchange and that we're going to have the free flow of information and that we're going to allow people to have the benefit of all of those APIs, the ones to the provincial repositories and the frontline systems. It's creating a structure that will be hard to even achieve in and of itself, and yet it's not probably everything that's needed. You're not ever going to change the fundamentals of the healthcare system.
The physician and patient experience of technology in healthcare at the moment is very poor. And there's a whole bunch of reasons for that, and that's not a Canadian problem. In fact, if I really go to the root cause of it, one of my favorite politicians of all time, President Obama, is probably at the root of a lot of it, because the Affordable Care Act, for better or worse, locked us into some technology choices that I think most people, and this is a real problem, right? Because there's this huge physician backlash going on at the moment where doctors are like, basically saying, I have all this good tech in the rest of my life, and then I go into my hospital and I have to deal with this, and this is really the best you guys can do? And so the question, but at the same time, we have this kind of base foundational lock-in thing going on that I quite frankly, I'm not sure how we get out of. What I think is important, and I'll pick up on a theme that Sacha talked about earlier, is when we think about quadruple aim, the IHI quadruple aim, we need to put equal weight on provider and patient experience as well as what we call quality and efficiency or population health efficiency. And focusing squarely on the user experience, the UI, UX, and pushing on that and not accepting, we have to not set a default position where hospitals get to put Epic in and say, well, we're done for the next 25 years. Have a nice time. And people are doing that. And I don't mean to pick on Epic. Epic is actually by far as I can tell, the best of the group. But I really didn't mean to hit it that hard. The point is that we can't accept bad UI UX in what we do as either providers or as patients, and we should work on it and accept it as an open question, not a closed question.
So as I would say, how many of you guys have read The New Yorker? There's a piece by Atul Gawande just last year. How many? Raise your hands if you've actually read it. Right? Why doctors hate their computers. And I would say right now, this is actually not just in Canada. It's actually worse in the U.S. There is a tremendous distrust of technology in the healthcare system right now. Doctors don't trust tech companies. Just going to be honest, because they feel super screwed over the past 10 years. Because they were really, and I remember when, it's only been in the last decade that we've digitized most of our electronic health records. It was, in fact, in 2006, less than 10% of health records were digital, and now over 90% are. So this has been a massive change, and there were all of these benefits that were supposed to come with digitization, and all it's done is created a burnout rate that is at record levels in the US. And so when innovators come, and we deal with it as we try to help innovate at hospitals like this, when innovators come and say, we've got this great tech that's gonna help your practice, how easy do you think it is for me when I have young physician moms who are having to do 2 hours of charting at night when they get home, they put their kids to bed because they have 30 charts and they've got 80 clicks per chart, and they're like, this is driving me absolutely insane. And there hasn't been any evaluation of electronic medical records, which has ultimately meant we spent billions of dollars, and it's hard for clinicians to say, well, what am I getting out of this? So imagine now how difficult it is when you guys are thinking, okay, well, I've got this other tech that's going to build onto that, and there's another password, and there's another thing, and how is that going to help me? So why I say that to you is not to be pessimistic, but to say you guys have to do the work now as we're thinking about of engaging and rebuilding that trust, demonstrating a real value proposition to what you're talking about, to actually make the technology make patients' and providers' lives easier in a real way. And sometimes the best tech companies I've seen actually follow doctors, follow patients, see what their experience is, and actually are like, I understand what your pain points are, and they do the work. And if you don't do it, which is actually what's happened in the past, you will not be able to break into a market right now that's extremely distrustful of new technology.
Thank you.
Here. Bravo.
There's a question in here, so I'm going to pass the mic down.
Thanks.
We're just going to have one response from now on, right? Because there's so many hands.
Thanks, Sacha, for saying that. As a clinician, it's music to my ears for you to say that, because you're absolutely right. And that's why I got into this digital health space a while back. But the question I have is, I believe that digital health can help address inequities, but I also wonder if it can create inequities. And I'm curious what your thoughts are about that.
Only one response, probably not mine. That's not to say I'm disinterested in it, I'm just trying to be
Well, I
efficient.
have one on inequities, which is Wi-Fi access. And so, like, I deal with a lot of my friends who practice in rural communities, and we in big cities have no idea how poor access is to internet in smaller communities. And we have to solve this because Canadians deserve better. And so the have and have-nots can divide along that line. I think that, University of Alberta research showed that not age, but it's socioeconomic status, employment, and education that impacts whether you're going to be savvy with computers or not. And I'm going to sneak in a reinforcement of what Sacha just said is, in the last decade, we now have 230,000 healthcare apps in the App Store, and we haven't seen a match. And everyone starts an app with a good idea. They want to solve a problem. We need to start doing something different.
Question in here. Going to pass the mic along again.
Hi. So building on the previous question about inequities, I already had this one planned. But do we need to actively incentivize solutions that will, promote equity or sort of put an oversight on things that could structurally sort of reinforce structural inequities, some kind of oversight to make sure that we're not making things worse than they actually are?
Well, I think that's more to the issue of if you're thinking about an integrated health system and population health. The idea is we shouldn't be measuring. I mean, we obviously have to do some measurement on process, right? Like how many computers, how many messages, some degree of understanding volume. But to be frank, that's not the goal. The goal actually has to be the quadruple aim, right? Which is, are we making patients' lives better? Are they having a better experience with care? Is the cost are we getting value for money? And do the providers like this? Are they happy in what they're doing? And I think if we focus on the big dot metrics, and we do that for a risk-adjusted population, then these are just tools. Like, these are not ends in and of themselves. They're tools for us to get to the journey, which is actually creating a better health system for everybody. And if the real thing, the real question is, how are we going to measure, how are we going to set the targets, set the goals of what we want our health system to be? And these tools are really just tools to get there.
Thanks, Sacha. And just so everybody knows, we have about 10 minutes left for Q&A, and then there'll be 30 minutes afterwards, which we can be in the space, so you can potentially speak to the panelists, and we'll just get to as many questions as we can in the next 10 minutes.
This hasn't been controversial enough. You really have to give us a zinger.
So I've been involved in patient-centric solutions since about 2012. So a lot of what you guys are saying is making me really happy because we have been, doing some research and looking into what a lot of the issues are with the system or pain points with patients and their families. So in my opinion, personally, it's 2019, we're almost in 2020. I feel the technology is there. But what I want to know is your opinion on some other missing pieces in our healthcare system. One of them I feel is really the support. You guys talked about it. Caregivers, patients, physicians. We know in general, aside from healthcare apps, most people will give up on an app if it's not useful. We're in a space where it's not, let's say in the banking systems, these people have incentives to figure out how to use that system. They'll do more for that. But with us, it's such a varied audience. I've worked where I'm trying to design a system for elderly patients and now, or maybe mental health issues for the youth. So again, the design requirements are very different. What I think, though, is that we're not supporting them, whether it's, as some people have mentioned, incentives, or there really just isn't enough education, because maybe people aren't seeing the light at the end of the tunnel, why they should continue to do this, and maybe the other part to it for education is, well, do they know where to look for these services? A lot of my friends, even my age, don't even know about the virtual services that are available today in Ontario, which is alarming. And it could save a lot of people and physicians time. And the other piece to that is we live in a world, just Ontario in general, people don't go to the doctor until it's, absolutely necessary because of the long waits and whatever else the issue may be. But I think what's missing is we're not educating people on early detection, preventative care. So I just wanted to get some opinions on those pieces. What is the government or what are we doing in Ontario to address those?
So I don't think technology is it's not an intellectual problem, it's not a technology problem. I'm going to take a very distinct perspective, but I don't know what kind of app you're talking about, but how good can they be without the data that we have that automatically feeds right into them and supercharges them? Then you add whatever functionality you want on top of it. Why would people, who cares? No offense, but what from a single hospital or a single family practice, that's not enough. We have drugs, diagnostic imaging, immunization, labs. We want to give that to you. And then all of a sudden, the person, whether they have diabetes or CHF or whatever, you've got all that heft of power of data in your applications. You haven't had that yet, and we want to give it to you. And your comment about virtual care, of course no one knows about virtual care, because almost no one gets it. Well, so telehealth is a teletriage, the phone, the creaky phone system. That's what's going to be absolutely changed with AI applications. It's going to be a holistic approach with, it's going to be modality agnostic and apply lots of AI to do symptom checks and all sorts of things. That's a whole different thing.
So here's what we're going to do for the last 5 minutes. We're going to try to do 5 questions, 1 sentence for your question, under a minute as a response.
So, especially when thanks Sacha for very insightful things that you mentioned there.
Winning.
To add to this, there has been a lot of conversation about technology, but no one really talked about processes and data in general, and the state of quality of the data and standardization. And we thought that how's that going to make really a difference for apps or others?
Well, I think Greg talked about the issue around data. I think the ministry has repositories of data that are pretty good, quite standardized. Actually, Ontario has some of the best health data in the world. We just haven't been able to unlock it yet. I think as we move towards unlocking it, some of it's not great, but a lot of it's pretty good. And I think getting it out there to you guys to work with, I think is a good thing.
The data's not all good. But there are technologies to fix it. And then there's an important part, it's true, it's a good point you're making, that clinical standardization, or not always standardization, but these systems aren't much without the brains added to them. The clinical best practices, standardization. So we want to create a translation service that takes smart stuff from HQO turned into OH, any other good clinical practice, and turn it into usable code for frontline systems or apps. That translation service in a holistic way has to happen, and it's not happening. It's happening in programmatic ways right now.
Perfect. Ready? 1 sentence, 1 question, rapid fire.
You've got probably 80% of the population dominated by 2 or 3 EMRs, another 80% dominated by 2 or 3 dispensing softwares. Greg, you nailed it on the head. There's not just the hospitals, there's the diagnostics, medication, so on. How do you help someone break down silos? You know, the last thing another doctor needs is another password. Greg, I'd love you to answer this one because you guys built Sadie, so help me out there.
I didn't build Sadie, but I think innovators in Ontario have to pick their domain intelligently. Some are going to remain not that competitive, and others are going to be more competitive. And all I can promise you is and we need all the supporters we can get, but the Digital Health Information Exchange, to have the free flow of information and to have those Fire-based APIs for almost everything we can get and deeper than how they exist right now, and turn OHTs into clients. They're little babies right now. They're going to grow into toddlers and teenagers, and we need to collectively help make them. I get, it's not your problem, it's more my problem, but we have to make OHTs smart purchasers of innovation, and that will be something we're working on.
Great. Another question up here.
Hi. So I had a quick question about clinicians. So as more and more clinicians sort of leave their kind of standard roles and move into health tech and kind of different roles, non-patient facing roles, how do you see clinicians being the most effective? Do you see us being more effective as experts in our field and influencing tech companies, or do you see us at sort of the helms of tech companies driving innovation directly? And how do you encourage clinicians to do more of that? That was one sentence.
I think that was a plan for me. So, in 1999, there was a Future of Medicine committee that tried to imagine what healthcare will be 2020. And one of the outcomes of that was the conclusion that 30% of work that clinicians do will no longer be clinical on average. They're going to be leaders, managers, advocates, researchers, teachers, and mentors. And so that came up with the CanMeds roles, which are now adopted worldwide. And we had to create management and leadership training for physicians to essentially upskill the ones in practice who'd never had the programmatic training, and then introduce that into the medical curriculum. After this session, it's a little plug, there's a meeting of the Toronto chapter of the Canadian Association of Physician Innovators and Entrepreneurs. And the idea behind innovators and entrepreneurs is that not all of us have to do what I ended up doing. I had this sort of a moment of like, what do I continue? And I said, it's insanity to try and continue changing and forcing people to adopt technology that wasn't designed with a deep understanding of our workflows that we needed. I need to step out of that, learn how to make software and start building those tools. But I think that we need to have a continuum of physicians who are involved in advising, adopting, perfecting, providing feedback, evaluating. And so I suspect that in 10 years, you're going to have 30% of clinical work being involved in some capacity around either data, interpretation, clinical best practices. And we're going to get rid of the current mantra of you publish an article, at some point Cochrane picks it up and puts it into a summary of guidelines. 7 years later, it's kind of adopted, and you discover that that guideline didn't work in the first place. But you're going to create rapid learning health systems that allow you to take evidence, put it into practice, take practice, put it back into evidence real time. And the clinical involvement is key, or otherwise we're going to end up with AI that's as bad as the software that we have today.
This is going to be our last question for the evening.
Thank you. Noreen from CBI. My question is this whole idea of removing the barriers to information transfer and improving that flow. We're not going to be the first people who are trying to solve this problem, definitely not the last. Where are the success stories coming from? Where's the inspiration coming from? Where are the ideas coming from on how to solve this problem?
I tell people that we're trying to be supremely uncreative in this endeavor on the information exchange. You've got high-performing American systems, you have Scandinavia, you have Estonia. I'm a skeptic in taking some of those solutions from very different political and social systems and importing them in Ontario. But when it comes to standards, whether they're messaging standards or transport standards or content standards, we want to be very uncreative, because a made in Ontario in that sense is going to suck, because you have to persuade so many more people with their systems that they have to comply to multiple ones. So we're not going to do that. Can I make a final comment?
I'd actually like all of you to make a final general comment or piece of advice.
Well, so we are in the bureaucracy, never mind the government itself. The government's democratically elected. We're Democrats, and we want to hear from as many people as possible, and people try to influence us constantly. So ITAC, you know what ITAC is? They influence us, and we have to be influenced by them. CCI, where's your voice? Are you going to collectively tell us something as HealthTO? You should. You should be trying to influence us, because that affects how we develop policy. So think about that.
Simply to say thanks for coming out. And honestly, I really am optimistic that the government's going to really try and facilitate and get out of the way. And there's a number of groups now in an ecosystem that can help you. And I really think the innovation responsibility falls on the people in this room. And so I think the challenge is there. Gauntlet's been thrown. Create good products.
I'm going to go back to history, and a Canadian physician, Dr. Osler, who invented the modern medical education system, tried to convince McGill to adopt that and couldn't, and they had to go to Johns Hopkins that adopted his method and then introduced through a Rockefeller Foundation-funded project that method of education to the 300 schools at a time. And so it's not a new problem getting innovative systems into the system. It takes a certain amount of persistence. It takes a certain amount of people who say, yes, I'm willing to listen, I'm willing to try and experiment. And it takes a certain amount of flexibility because we as innovators collectively have to listen better to what users are telling us and what governments are telling us, and sometimes ignore the rules, sometimes put pressure, be creative and adaptive. But I don't think we have a choice because the current status is not acceptable and we can and should do better.
I think we're moving now, and I won't go back on the implementation challenges and the policy challenges. I think they're all there. I'll try to go to the next set of challenges, which I think are going to be around curation. We're at a point now, because information in the healthcare system is like food for human beings. When you're starving, all you want is more information. It's only when there's abundance and plenty that you realize that diabetes is a problem too. And we are going to have information diabetes in the health system very soon. We're going to have way too much information, and we're not going to know what to do with it. And the question of curation and usable systems is going to become, as we achieve what it is we are achieving now. I mean, I think am I safe to say that everyone in the room believes that we're going to see a digital and virtual healthcare system in the next 10 years? The question is going to be, what do we do about information diabetes? When we have too much information, we start having chronically unhappy patients and providers because of too much information. And that curation challenge, we're just beginning to really get our head around and get thinking about. So thank you, though, for coming today. You guys have been great.
So I just want to thank each of you for taking your Thursday evening to come and join us for this panel. What did you guys think? This is only the second time that we've run a panel for HealthTO, so we're open to feedback and suggestions. So thank you for coming out this evening. We have 25 minutes left in this space. So what we're going to do is move out of this room and into the hallway networking area again. And then we'll let you know when it's time to leave if there's stragglers. And our next HealthTO is going to be in January of 2020. So thank you so much.